aplastic anemia, the large majority of the aplasia are idiopathic. The list of the diseases is very long, but if you think about this in your practice, majority will not be part of your practice, right? So, cancer treatment, radiotherapy, drug reactions, anticonvulsants, sulfonamides, chloramfenicol, these are now very rare causes. Even though you are using anti-epileptics so much, you rarely see typical Pancytopenia related to that. Then the old NSAIDs which are not used any longer, anti-thyroid medicines, again very few cases, very rare cases, and you know that when in hyperthyroidism also you rarely come across these. The toxic chemicals, unless you are in an area where there is industry with exposure to benzene or some of these solvents, you will not see Pancytopenia. One thing which is not in this list is B12 deficiency, which is common to our region. That is something you easily diagnose. The other common thing which is not here is methotrexate. A lot of people for rheumatological illnesses taking methotrexate. Typical history is that patient has been taking it for a long time, and now suddenly there is Pancytopenia. Mostly it is due to additional viral infections, and sometimes because the patient does self-medication, that there was more pain, so he started taking more methotrexate. This happens more commonly with newly diagnosed patients. So they will prescribe methotrexate, they think that this is for my pain, so it is a painkiller, and then more pain, so they start taking every day. That's kind of the common history we see. These viruses again are very rarely the cause of aplastic Pancytopenia. Immune disorders again extremely rare, and PNH, thymoma, pregnancy, anorexia, all rare. And these are such that mostly from a very basic history you will come to know if any of these exist. So they are not like you have to dig a lot into that trying to find the etiology of Pancytopenia. So B12 we easily frequently check, medicines will be in the history. In our country, we have also asked the history of some alternative medicines, which you don't know, which may sometimes lead to that. Others are mostly self-explanatory. We do a kind of complete workup for very good evaluation of peripheral smear, physical examination complete, sonography, abdomen, chest X-ray, and blood test for chromosomal breakage study, that is for the Pancytopenia anemia if patient is under the age of 40. So that is, so even though Pancytopenia is a genetic disease, but it can manifest up to 40 years of age approximately. So it doesn't have to be a pediatric patient. The other evaluation is important to look for any other signs of congenital disorder. So inherited bone marrow failure syndromes may have various other signs on evaluation, which if it seems out of range, then you order for that. We frequently order the whole panel, inherited bone marrow failure syndrome panels. This is the bone marrow of the aplastic patient, and this is the normal bone marrow. The aplastic anemia incidence is less than about 2 cases per million. India it is about 6.8. This is significantly higher in Asia compared to bone marrow failure disorder to not overlap. We have to be careful on the pathology side, especially at the time of diagnosis. So rarely we can have hypoplastic myelodysplastic syndrome. The typical MDS bone marrow is hypercellular, most common, but not all. So one has to look for such as dysplasia. Rarely you can have acute myeloid leukemia also, looking at the there are clusters, very few clusters. But for a good hematopathologist, these would not be an issue. So we don't face that with association or something. Then we need to use great lines. And inherited bone marrow failure syndromes, PNH, LGL, large granular lymphocytic leukemia, very rare ones. So some overlap between Aplastic anemia and NADIAD, because both are ultimately disorders of the stem cell, and Aplastic anemia can ultimately go into MDS also, clonal evolution. For clinician's point of view, this classification is very important. That how do you define the seriousness of the patient illness in front of you? Because the patient may look fairly well, and the numbers may be deceptive in terms of patient well-being, a number may not match. And at that point, how to take decision is most critical. So the severe is where bone marrow cellular is less than 25% of normal, or 25, 50% of normal, less than 30% residual hematopoietic stem cells. But most important is criteria: neutrophil less than 500, platelet less than 20,000, or reticulocyte count less than 20,000. So absolute reticulocyte count is important, not the percent. That you start asking your pathologist that they have to give absolute reticulocyte count. If it is not given, it is easy to calculate. It's the absolute red cell count times the percentage of retic count you will do. So it's not a complicated thing, but we have to start thinking in that direction. And severe aplastic anemia is where neutrophil is less than 2. So these are the people, very severe ones, who will die on you in a matter of few weeks or sometimes even days from major sepsis. So if they will come with fever, then you have to use the highest level of antibiotics, so to say. Then you start them with 4th generation cyclosporine or meropenem and aminoglycoside. Don't wait for blood cultures, patient is looking stable. I don't want to start with the highest level of antibiotics. Don't try that. These are people who will die very severe. Gives you a little more time, but depending on the numbers, you have to be very careful also. So I think this is the very, very important slide. So the role of non-hematologist here in supportive care, the antibiotics most important, and antifungal also. Transfusion. It is very important that in terms of the outcome of aplastic anemia, there is a very good correlation between the number of transfusions. So if the less than 10 transfusions, then you get almost 80-90% cure rate or remission rate. Once the number goes between 10 to 50, it drops by about 10-15%. And more than 50, the same number drops by about 20-30%. So even with the same treatment, be it transplant or ATG-based treatment, you are reducing the survival significantly just by the number of transfusions. Simple correlation. So what is your role? That use blood products sparingly and while the patient is not making is trying to start treatment, you are still doing the diagnostic workup. Make sure that the platelets are as far as possible single donor platelets. That means instead of 6 or 8 transfusions, you are giving one donor exposure. For the red cell, there is no magic number that hemoglobin must be more than 8 or 7 or something. It depends if the patient is very stable, non-cardiac, young patient, then 6 grams is also okay. If there is a bleeding, then obviously it will be more than 9, 10. But otherwise, majority patients, 6, 7 hemoglobin is sufficient and don't transfuse. In the platelet transfusion also, non-bleeding patient, 10,000 platelet is very okay. We don't need to transfuse. If there is sepsis, fever ongoing, then the same dose can be more than 20,000. But don't transfuse because platelet is 40,000, 30,000. Just everybody is worried that this number is very low. That should not be the reason for transfusion. Then, of course, we discussed about the fever. Any fever, be very, very careful. Immediately lead to admit and IV, not even outpatient treatment of any kind. So, what is the current standard options for the treatment of aplastic anemia? That it depends on the age. So, if age is less than 35 to 40 years, and if there is a matched donor, fully matched sibling donor, then you do transplant as a first choice. Now, if there is no family matched donor, then even in young person, you go to the Orset EG with cyclosporine. And thereafter, if there is no response at all, second line you can think of it. Now, so some people who say that if the person is very, very fit, then even 40 plus age, you can think of transplant in the front line. So it is the biological age, not the chronological. But one has to be very careful because the risk-benefit ratio here of transplant versus non-transplant is very important. So this was from the British guidelines in 2016, and the more recent, there are no guidelines from the society, but from today, the only difference is all the what I mentioned is same, but here you get this part that the when we say not transplant,
pointer.
So now air thromboplasm is part of the initial treatment. That is the only difference in the treatment. Rest everything is same. Young patient, matched sibling, transplant. If no matched sibling or patient is not young or comorbidities, then you go to the ATG, cyclosporine and air thromboplasm. Now, the reason for doing these tests for Pancytopenia anemia and other inherited marrow failure syndromes in the age group up to 40 is because if there is any of such diseases, then ATG will not work. So you do all this treatment and you find out after a few months that it is not working, and then you do the workup, you will figure out that it is because there was already an existing marrow failure disorder. So coming to this so now This is one of the very important slides that most cases are idiopathic. So please don't keep on looking for etiology. This is what we see very commonly, that people are trying very hard to find an etiology of aplastic anemia. Patients are getting more and more tests done, more and more history being taken, and they are trying to get into a lot of details that maybe this person was taking some Ayurvedic treatment. Then let's find what the Ayurvedic treatment was, what exactly were the drugs, and whether what is the content, and whether that can cause it or not, or some whatever other things, or some painkiller he was taking. So then trying to get a lot of details of that. The very important message here is that other than the industrial chemical solvents or some of the major drugs that we saw, even in the drug induced aplastic anemia, you wait for maximum of 2 weeks. Maximum. If it does not recover in that time, you go to the treatment of aplastic anemia. This is a very important understanding. We have asked this repeatedly to the experts in the field who have done this research on the aplastic anemia regimens. Professor B. Young is considered kind of the father of aplastic anemia modern treatment. Very clear, very categorical. That even if you wait and find out, it doesn't matter, the treatment is still same. And while you are waiting, steadily you are putting the patient at risk of dying, or because of multiple blood clots, the result will continue to drop.
Yes. We have seen patients taking methotrexate, developing aplastic anemia, dying within 3-4 days. So what should be our approach in that? We should wait for 2 weeks, or we should be aggressive in that?
So, as I mentioned initially, the methotrexate ones are the one where we wait, because there are very few drugs where we wait. But yes, any drug, if it does severe pancytopenia, then it does pose a risk to life. And those patients, sometimes we've seen with 100 WBC or 400 WBC, severe mucositis, so they will get gram-positive bacteremia, fungemia. So those patients need very aggressive treatment of infections, and occasionally we give them granulocyte transfusion to tide over the crisis. Those are slightly different from the typical aplastic anemia. We don't call them aplastic anemia because there we have clear-cut different pattern of illness. So they will recover in about 1 to 2 weeks time. It is very uncommon for methotrexate-induced pancytopenia not to recover in 2 weeks. But these 2 weeks can be very difficult, as you rightly pointed out.
I have seen few patients, they collapse within 3-4 days. Pancytopenia, WBC count less than 200, platelet less than 20,000, hemoglobin less than 5, severe mucositis, they don't respond to anything.
So, very severe aplastic anemia, which we defined as less than 200, the same number applies to not typical aplastic anemia also. For example, agranulocytosis, your platelet and hemoglobin may be normal, but even if you have only agranulocytosis and less than 500 neutrophil, you should be very respectful of that condition. And less than 200, it should be, I would say it is a time bomb, you should not keep it with you. Send it to higher center. This is the patient you don't want to treat. You are going to burn your hands, almost certain. Less than 200 neutrophil is very bad. So they would need all these things and the granulocytes. So we give them granulocyte transfusions to tide over this period. Maybe we would need 2 or 3 such infusions. Granulocytes require a donor, and the donor has to be injected with GCSF and dexamethasone. So So it is not easy to find these bones because patient relatives not easily agree. In those cases, we give buffy coat for the few days until we can find it. Buffy coat is not very great, but it gives you, say, if you are having 200 ANC neutrophil, you might get to 400, 500. Something will be there, and that also needs preparation of some kind because the blood bank has to be informed. Because they throw away this thing. So you can tell them in advance, and you have to be very liberal with the antibiotic, antifungal of the highest level. So this is a pure medical emergency. So thank you for pointing that out. It is as bad. So don't keep on looking for etiology and don't try steroids, denazole, cyclosporine. This is another practice that very commonly happens. That we hope that with old teaching, when there were not many drugs available, people used to try steroids in any kind of pancytopenia. So this is bad. First, you should not try that without doing a bone marrow because some of these would be actually lymphoid malignancy and you partially treat it. Then very difficult to make a diagnosis. Other thing is that the response in aplastic anemia is only about 10% with steroids. So and that too not very long. Denazole can take several weeks to months. Cyclosporine alone again can take very very long time to have a response. So don't keep on trying that. Nowadays, if patient is not affording, then these whether you send them to government hospital or some Yojana or trust hospital, you must know that the standard treatment is ATG based, not the these oral medicine.
Any role of GCSF, folic acid?
I mean, it's okay to give. We would not fault anyone for doing that because at least it is not going to harm the patient like steroids or other things. But GCSF going to work? No.
So we do see lot of patients.
Leucovorin also no. Leucovorin is only for high dose methotrexate toxicity because methotrexate blocks folic acid conversion to folinic acid. So when you give folinic acid, you are rescuing those patients from that action of methotrexate. For everybody else, simple folic acid and folinic acid are exactly same. It's no difference.
We do see lot of patients of HIV or maybe sometimes HBH positive. They present with very low leukocyte count, 900, 1000, totally asymptomatic. Should we do something for that?
So those are not typical aplastic anemia. Because as we discussed the first list where you see HIV, then you treat them differently. If that list you find anything, then majority you treat specifically for that, except as we said drug induced, not wait for more than 2 weeks. So HIV majority will respond to antiretrovirals, and if they are already on that, you have a long list of infections that can involve the marrow, and even sometimes malignancies which can involve the marrow. So that would require a whole different diagnosis. Yet, while you are doing the diagnosis, remember those numbers. So if it is less than 500, be very respectful. If less than 200, don't keep it. Whatever the diagnosis. That is a bad list, regardless of whatever the diagnosis. So transplant is first line treatment as we discussed again, that only for less than 35-40. This again I am highlighting because we see many patients who are waiting to find a match, and they have this in their mind that transplant is the best treatment, so they must go for transplant. And if there is no match from family, then they will keep on going around looking for donor, and they will be, spending several months with intercurrent infections, many transfusions, and they don't want to go for this so-called inferior treatment, which is ATG based. Very recently also, somebody like this I saw, 6-8 months, about 30 years old woman, and the father is frantically searching for transplant options, and then he is almost ready to go for half-match transplant. When in fact the half-match transplant results are so much poorer in that even in the Western world they don't recommend that if there is no match donor. They don't recommend haplo or mismatch transplant as first option because the results are not as good. And we know in their hands, in the malignancies, the results are almost equal. Whereas in India, we know from the official registry data, the ISPMP data and all, that even in malignancies, the fully matched transplant results are here, haplo is here, and for some reason our matched unrelated are even lower than haplo. So you must remember that people should not keep on waiting for that. We lose patients dying from infections or bleeding during that time. I think this we already discussed. So now I will run through this very quickly. This is more of aplastic anemia details. So corticosteroids 10% response or occasional, ATE 40 to 50%, ATE plus cyclosporin 60 to 70, and when they recur, then about 30% response. Important point is to remember that the response to ATD cyclosporin are mostly partial. So patient will not get a normal CBC. We advise them this upfront. Otherwise they feel that treatment करी लागती અને જો platelet normal ના થયા WBC normal ના થયા. So out of the 3 lines, most people will have at least 1 or 2 lines not complete response. Means platelet will stop at somewhere below 1.5. It could be 1 lakh, it could be 80,000, even 50,000. So it will stop there. Similarly, WBC 3,000, 4,000 will stop there. Hemoglobin 9, 10, it will stop there. Only about 10%, 20% people have complete remission. It's a normal CBC. So we advise them upfront. They should not feel, and you should not feel that your patient has is not getting expected results from the treatment. This is the very well known standard. By adding the L-thrombopath, we have about 50% complete remission rate. It has improved significantly, but still not everybody will get complete response. And still this is sufficient for the daily life, for majority of the life. They would become transfusion independent, and for the large majority of life they would not have an issue. These are just some of the studies, but basically showing that the response rate is about 50 to 70%, and the 4-year survival is 85%. CR rate only 10. Randomized trial of horse ATE versus rabbit ATE, where the rabbit ATE is 33% result 6.37, and this is almost double with horse ATE. This is the value of having clinical trials or randomized trials in medical field. We all felt before this trial that rabbit ATE would come out to be superior because it is a more potent immunosuppressant. And practically, if you ask before that, most hematologists felt that rabbit ATG is better. And if somebody in their practice was using horse ATG based on whatever data, then others would frown upon that methodology that is the inferior data. Then when randomized trials were done, completely opposite. So much bias that we have from this very little data that we see from our individual patients, and not having the standardized criteria and all. This is very, very good. That's why I was putting this here.
Also not science the other way.
Yeah. So exactly.
So,
Even in
trial
our
also is other way.
transplant, yeah. So even in our transplant, rapid ATG is better. So based on that and based on this data and all, everybody showing that rapid ATG will come out this way. And this is not just one trial, multiple data sets to show. So this is the very, very important. I mean, not related to today's talk, but I think overall is medical field, the value of randomized clinical trials and how things can be so different. This is again just showing the same. So, we have tried a lot of different things to improve upon ATG cycloscoring, and that included adding androgens, nothing happened, megadose steroids, no high dose cyclophosphamide, moderate dose cyclophosphamide, adding MMF, cyclophosphamide. I mean, these all made sense otherwise in the immunology field that it should improve the outcome. That's again the value of clinical trial, that what we think has to be improved. Add GCSF to ATG-CSF, no improvement. Prolonged CSF instead of 6 months to 2 years, it reduces relapse, but not completely, it's kind of delayed. So then came this L thrombopar, which you know about in the field of ITP, maybe aware. And this includes this is first in the refractory Aplastic Anemia. Those who failed ATG and cyclosporine, and the dose here is up to 150 milligrams. Generally, we nowadays start with 150 milligrams. So about 50% responded, and over the time from 16 weeks to at later follow-up, initially it was a one-line response, usually mostly, and then it improved at multiple cell lines improved. Platelet improved, hemoglobin later, neutrophil, bone marrow also improved. So these are multiple studies. As I said, we will go through this very quickly. So the first line treatment then, L-thrombopar was brought to the first line, that ATG plus cyclosporine, again published in New England Journal. And here, L-thrombopar was added from the start. What you can notice here is that the complete remission rate here was 58% and 94% response rate. So practically everybody is now responding by adding L-thrombopar. The drug has also become cheaper now with multiple lineage generic options. So when only the multinational was there, the cost of ATG plus cyclosporine was about like 7 lakhs, and the L-thrombopar was another 6 lakhs. So it is to be given for 6 months and in high doses. The normal ITP dose is 25 to 50 milligrams. Here it is 150 milligrams. Significantly higher. So these outcomes are now very good. This is cyclosporine continued for 2 years versus 6 months early relapse. So this is just a larger data set, 178 subjects and longer median follow-up. What is important here is that about 5% of patients will develop a NDS or AML over the years. This is something could not happen with transplant. So that is why in younger patients still we prefer transplant if there is a massive. Otherwise, with 94% response rate, why take any risk of transplant? So the randomized trial then with or without L-thrombopar addition, and the At 6 months it was 80% versus 66%. So again now adding Adalimumab in the front line is the standard of care. For those who cannot handle ATE for some reason, whether very frail, old, or ATE not available, there this trial of cyclosporine and Adalimumab without ATE, and the response there is about 72% at 6 months with transfusion independence. But the CR, complete remission, is only 5%. So, if available, ATG is still preferable, ATG based treatment. For India, we should know about Nomiclostin. This is Indian generic. It is not approved for severe aplastic anemia, but in refractory cases, all of us have used, and it for 10-20% people in refractory cases who respond well. This. We have discussed about the transplant. There is no randomized trial interestingly comparing IST into ATG cyclosporine and Adalimumab versus transplant. There is no randomized trial. But based on the historic data, all the guidelines still keep recommending that transplant is better. However, this comparison seems better below age 20. Between 20 and 40, the risk-benefit ratio becomes more difficult, and more than 40 is certainly not favorable. Now, these studies have used bone marrow as stem cell source because otherwise the GVHD rate is very high, chronic GVHD. Now, in India, majority use peripheral blood, rarely use bone marrow because bone marrow, the engraftment is delayed, means bone marrow recovery is slow, and we all have worries about multi-drug resistant bacteria. So, Indian transplants are almost always peripheral blood, and that makes it difficult. So, you get significant chronic GVHD, about 40% chronic GVHD, which is, if you see patients with chronic GVHD, quality of life is very poor. So, for that reason, what we mentioned is that HCT is preferred in very young, less than 20, and fully matched sibling donor. Not otherwise go to the non-transplant options. And these we have discussed, just summarizing that if you see Pancytopenia, make an early diagnosis, get bone marrow biopsy done quickly. Untreated death rate is very high. If less than 200 within 1 to 2 months, so urgent referral for these patients is important. They may not look very sick initially, reduce the number of blood products. Another important point is that response to ATG based treatment may take 3 to 6 months. This also we counsel to patients that injection given, discharge, numbers of this would not happen. That happens with transplant. So that's another major advantage of transplant. If you can find a donor quickly and the white cell is less than 200, in about 15 days your count will be up. So if you can get everything done fast, then it is a good option. Otherwise, no. That's all. Stop here. Any questions?
Sir, chemotherapy induced aplastic anemia. Chemotherapy induced.
Yes.
What is the line of treatment?
So chemotherapy induced aplastic anemia, we use the word more like pancytopenia. When we use the word aplastic anemia in our language, it becomes this kind where we talk about transplant and ATE and all. So chemotherapy induced cytopenia, you just have to wait it out. Over the time it will reduce unless the patient has been treated with multiple lines of chemotherapy, which can happen in very advanced solid tumors or even hematological malignancies, myeloma, any others, where the bone marrow is very beaten up and there you don't have any option.
Sir, how to differentiate Pancytopenia, whether it is aplastic or myelodysplastic, clinically from blood picture, not bone marrow?
So So
are there any differentiating points?
yes, there are points. So good pathologists will flag those signs, like they will find some dysplasia in the neutrophils, palpable anomalies, sometimes nucleus. There will be normoblasts in the blood, occasional ones with abnormal looking nucleus, karyolepsis, not very good smooth nucleus. So in the myeloid series, they can find some signs and suggest. Other than that, I mean, they are very soft signs, very non-specific. And even if you find those, then ultimately you will need bone marrow to confirm, because based on that you cannot do anything. So yes, it is. I mean, it is good to have a pathologist who will flag it so that you may be able to convince your patient for bone marrow early. But regardless, if the first list that you saw and B12 deficiency, which is not mentioned there, if none of those things are there, then very early bone marrow is required. More so if the numbers are met. So if the neutrophil is less than 500 or platelet less than 30,000, then it is better to get bone marrow early, because to do a bone marrow takes 2 days for diagnosis, I mean the reporting, so anyway you are spending. So when we have less availability of tests, less availability of treatment, then these things are more important than trying to do things from peripheral sphere. Nowadays, I think it is more important that we look at the numbers and we take decisions.
Sir, one of my patients, around 35-year-old, is coming every 3 to 6 months for blood transfusion. His HB is falling around 5, WBC around 3,000, 3,500, platelet around 40,000. He comes with 2 bag of blood transfusion. He asks me that I will pay you 1,000 rupees, give me 2 maybe. In evening I will leave. It is routine for him. He has been investigated somewhere in some medical college. He does not come with any papers, but he instructs me, give me blood transfusion and I will leave by evening.
This could be MDS, this could be moderately severe aplastic anemia, where we mentioned that those are the patients where you may not go to ATG right away. If you could try with cyclosporine and L-thrombopath, over several months they may improve. So those are the 2 most common diagnoses, but rarely we could see other things also, like HIV. Right?
This is very common. We do see a lot of such patients. MDS, probably they are MDS.
I mean, those are the, so all of our practice, we have patients who don't want things done, and they will, for whatever reasons, either cost or fear or finding something, fear of procedure, they will not agree. That I understand, but at least we should be clear that this is not standard, and that we should be at least telling the patient and even documenting that you need bone marrow biopsy, because tomorrow if this MDS converts into AML, then you would have sudden downfall. Suddenly his condition will be very worse, and that time it will, they sometimes blame that proper diagnosis is not. Even lymphoproliferation, low grade lymphoma could behave like this for a long time. We have patients with low grade lymphomas where all the workup is normal except bone marrow biopsy. And very easy treatment, only rituximab or RCVP or PR, those are very gentle chemotherapy and will be cured. So you counsel them that there are many diseases which can be treated and it would lead to a much better quality of life for you. You will not end up spending so much money. You will not be on the edge, living on the edge. If he needs a, say for example, he has a heart attack or any angina, he will not be able to get angiography or angioplasty done. The cardiologist will say, I can't put stent, your platelet has water. If he needs a surgery for some reason, he will be stuck. He has an accident, fracture, hernia, appendix, so many things, knee replacement. So he may be happy right now and thinking, I am avoiding all the issues, but potentially EPH, any surgery he needs, he will be stuck. And at that time, he would anyway need to go for a it may take some time. The response to treatment may take even much longer, or most of these will be slow treatment. So we have to tell them that while you are doing this, these are the chances we take.
This APG, how long do you take?
4 days.
And it's finite.
Yes.
Because we don't need to have a second dose.
So, large majority who are going to respond will respond in the first time. Second dose may be even if there is a relapse after a significantly long period, that they had a good response and now they are recurred. Then, if you give it over longer than 4 days, then the higher chance of serum sickness. So you can give there are protocols are either 7 days, 10 days, 14 days. That for elderly or frail, that there is a tolerance issue because when you give there is a lot of hemodynamic instability. So, but there is no major advantage in this.
Use of Cefran and cyanide prophylaxis for them.
So what we do when we admit them, we give them some IV antibiotics, generally infantile monoset or very low count and fourth generation cephalosporin. Because the first day you start, there is going to be fever. Practically, almost everybody will have high fever from day one. We give them steroid as a serum sickness prophylaxis from day one to day one. Cyclosporin we add once the steroids are taken off, which is after about 2 weeks.
For CME or hemostasis,
We don't know. Fluconazole, some people would give during the steroid period, plus minus, because you are giving steroid for first 2 weeks, but not long term. So, fortunately, the aplastic anemia patients, while they have not recovered their count, are very, very low risk of fungal infection or hemostasis. We don't put them on any prophylaxis.
and is there anything to know how each of them work? Like, because I don't know if there is a T-cell disorder in them or what's anything new on the mechanistic?
I mean, these drugs are all very old, and I'm not aware of any major research going on that we can read about these all over daily updates that we get from ASH or ASCO. There is rarely anything on this. Very, very good.
So the question is, lot of times L-promoprid is now any surgeon often has low platelets. And is this a generic to use it to get them to operate, or how do it work?
Or any kind of low platelet.
See what happens many times you see a patient, everything, all counts are okay, hemoglobin is okay, WBC okay, platelets are 40,000 is planned for the prostate surgery. So, ऐसा थोड़ा काफी होना है. How good or bad, or what is the, because we haven't used this drug as much as of course you know. So
L-promoprid works primarily in ITP. It would not work in MDS. There are studies kind of maybe desperate long-term things, but the typical few days response within few days, no other thing. ITP alone is a super drug. No side effects of steroids will be given to practically anybody, elderly, this, that, diabetes, not have to worry about sugar, if we use that. So that's the excellent drug, and about 5 to 7 days, every patient will find a right. But other than that, it will be so, and then even if you get response, then you stop, then it will immediately come down. So it's not like steroid that it will provide a long-term response. The long-term response in ITP with alcohol is only about 30% of people, and that too if you are given it for several months. So after 5-7 years after surgery,
How does it act? How does it act?
Alcohol, it's a TPO receptor agonist. So thrombopoietin, which is produced by liver, it stimulates the megakaryocytes to make platelets. So earlier the thinking was that in ITP production is very good and it is the high distress. That's the kind of traditional
Yeah,
thinking.
that is the thinking still now.
Right. So most people, so that means the production વધારવાનો કોઈ અર્થ જ નથી. Production is anyway excellent. Megakaryocytes are actually doing overtime. So why give this drug? Now ITP is like a waste basket of possibly so many things that we don't understand. So when they started doing these studies, more detailed, electron microscope, these that, they found that about 30% or so people are actually not making more platelets, and then some others are making but not enough to
Compensate for this.
compensate, so not enough as it should, like the response is not adequate. So based on that, this was used, that increasing the production actually may work, and it's surprisingly it is superbly effective. So there are some other potential mechanisms and all theories, but that's kind of the way.
Coming back to this question also, 40,000 platelet, what should we do if surgeon insists they want to go for surgery? Is there any role of steroids?
Without diagnosis,
You don't feel anything, no HIV, no hepatitis, nothing.
so if you have done your workout, including bone marrow, then you can stamp it as ITP disease. Now I understand that majority of your patients for pre-op clearance do not agree for bone marrow. So if it is a young patient, say less than 20-30 years, then if peripheral smear is very good, clean, and you have a pathologist who you trust that he looks at this very nicely, and there is no sonography is normal, no lymphadenopathy, no these other things looking like, then it is highly likely that this is ITP. As you go in older age group, the percentage will be different because then more other diseases will get it. The infiltrating disorders, other bone marrow disorders, MDS, this, that. So you cannot be so sure. Lymphomas. So in such cases, giving steroid, there is a potential danger of masking the diagnosis and creating a lot of long-term confusion in the diagnosis. There, L-thrombopath may be used because at least no risk of masking other things. So if you think that based on the peripheral smear, everything else okay, no disease, then this is potentially ITP. You give the patient L-thrombopath for 7 days. If it works, get the surgery done, continue for little longer so that post-surgical recovery is complete, and then possibly have IT. Everybody else, I think you should insist on workup and at least document it, because you go to the other person who will diagnose and patient will come back to you. These things now happen more and more.
In past, we have seen many gynecologists prior to doing cesarean section, full term lady undergoing cesarean with no platelets. They used to do methylprednisolone and then taken for LSC. Now, how logical it is, I don't know, but they do.
I think this goes back to like many of the things that we mentioned earlier, that 10% response in aplastic anemia. But a lot of people felt that મારા ઘણા બધા પેશન્ટને રિસ્પોન્સ આવે છે. And this is what happens, that this is called the recall bias, that when you have a success you remember that, or sometimes failure you remember, and that is why we need statistics and all this to spend millions of dollars on clinical trials. It's very unlikely that it would have worked on anything but ITP. And this is all of us have. हमारा patient है बहुत सारा system, हमारा बहुत सारा start doing that, and then you analyze the institution data. We last 50 patients and what I was thinking how to fellow takes out data and you feel your perception and the data is very different.
So, whenever transplant
So match sibling bone marrow transplant in private is about 15 to 20 lakhs. So the initial quote may be 15 lakhs, but you have to remember that there is a long follow-up after that, which would be easily fine. And that is if you don't get GVHD or other major complications. Anything other than match sibling is almost double. Because match unrelated donor, the cost of the stem cell is about 8 lakhs. And plus more supportive care, longer issues post. Same thing with haplotransplant, so family donor, but the post, almost everybody gets CME. 90% people will get CME. And then some will get other issues and also get CME. So it's almost double. Now, fortunately, Ayushman covers that to some extent or more. So private will not do it, but trust hospitals will take it. GCRI will do it. Some trust
They
hospitals.
don't cover treatment of CME. CME ની ટ્રીટમેન્ટ કવર નથી કરતા. આયુષ્માન નથી કવર.
હા, એટલે શું થાય, પણ ઘણું બધું તો ઇનિશિયલ કોસ્ટ પેલી 10-15 લાખ બહુ નીકળી જાય. એમાં કંઈક છે કે they have to pay some part, 5 lakh or 3 lakh or something. And the major trust hospitals, what they do, they have a lot of fund. So they will cover these other things. So ultimately patient નું કામ થઈ જાય. એટલે એમની પાસે એક્સ્ટ્રા ફંડ હોય કે પેશન્ટને કોમ્પ્લિકેશન થયું, ઘણા ખરા કવર થયું. પ્રાઇવેટમાં પછી એ બધું